And I think it's probably a good idea since not all of us are intimately familiar with the logo thing. So welcome again, everyone, to sign out with the professor here at a sort of unique time and a unique opportunity. I am really happy to introduce our presenter today for many reasons. But I first became acquainted with Dr. Atwee when she came to our residency program, and I won't say how long ago that was. It wasn't all that long ago. And she came to us having done some pathology training in clinical pathology in Lebanon and completed her medical studies there. And then joined our faculty, did a fellowship at our institution following her residency training, and has just been a wonderful addition to our faculty in the area of GYN pathology. And so, Doa, I'm going to turn the podium over to you. I'm going to mute myself and go off the camera. And we will reconnect towards the end of the hour as may be needed.
Thank you, Dr. Hassel, for inviting me and for your kind words. I'm very pleased to be on the platform as well. So today I will be showing some interesting GYN path cases. Some of them are rare, others are more of what we see in our daily practice. For all the cases that I will share, I will show first the actual slide, and then I will have a very brief PowerPoint slides, just 2 to 3, just to kind of summarize and reinforce the educational points. So please feel free to interrupt me to ask questions, or maybe in the comments. And if you want to suggest the diagnosis, that would also be great, or like the differential diagnosis. And I think with that, I will go ahead and get started. So case number 1, this is a 25-year-old lady with a large 8-centimeter polypoid mass. And this is the hysterectomy specimen. I will start first with low power just to show the different parts of the tumor. So this was the kind of the exophytic part of the mass, or the polypoid area of the mass. And we can clearly see like 2 processes going on here. First, we see a lot of cystically dilated glands, and the dilatation seemed to be kind of rigid, not loose. And then we see an area of basically pure spindle cell growth, very monotonous, with, when we go on higher power, we can appreciate easily a lot of mitotic activity and no glands in between. And then when we go to the myometrium, I'll go back on low power, we can clearly see that there is some sort of infiltrative process in the myometrium. And when we go on higher power, we can appreciate the kind of cells. So they have a plump eosinophilic cytoplasm, and some of them has like a eccentric nucleus, typical of the rhabdoid appearance. So like right here or right here. And others have these elongated cytoplasmic extension, or what we call strap cells. So this is typical of rhabdoid differentiation or rhabdomyoblastic differentiation. So the combination of, lower grade areas with cystically dilated glands sort of condense the stroma around the glands, and then areas of pure spindle cell growth, and then areas of rhabdomyoblastic differentiation that infiltrate into the myometrium. So if anyone would like to suggest the diagnosis, that would be great. I'll wait for a few seconds. Okay, so this is an adenosarcoma with sarcomatous overgrowth. So, and then heterologous rhabdomyoblastic differentiation. This is a very typical example of this entity. It is a rare entity. I also wanted to show other areas of the tumor right here. So there is sort of polypoid projections within the glands. and also a little bit of like a little leaf-like architecture or more of like stromal projection. So this is a case of adenosarcoma. Just to kind of summarize quickly the main features of this tumor. So it's a biphasic tumor that is composed of benign Müllerian glands and malignant stroma. Typically, grossly, it will form a large polypoid mass that fills the endometrial cavity, just like our case. And the main microscopic features are the periglandular cuffing of the malignant stroma and these intraluminal polypoid projections, the cystically dilated glands, and it's typically a rigid cystic dilatation and not loose, sort of what we see, for example, in atrophy in older females. And the glands are benign, and they typically have a proliferative type endometrial epithelium. We define sarcomatous overgrowth as more than 25% of the tumor composed of only neoplastic stroma, which we had in this case. And the stromal component in this case is would be positive patchy usually for ER, PR, CD10, and WT1. Quick pictures. So this is the sort of the intraluminal polypoid projections of the malignant stroma. This is the condensation or the cuffing around the benign glands. And this is this very similar to our case. So the lower grade area and then the areas of pure spindle cell growth, which is typical for sarcomatous overgrowth. And I think that concludes the first case. So if you have any question, I'm happy to answer. Okay, no question?
Big question. Sorry, is there, do you have to mention their heterologous rhabdoid component?
Yes, I would definitely mention that. And in this particular case, the metastatic component was actually all the rhabdomyoblastic component. And because if it's just a low grade, when they do a hysterectomy, it's pretty much cured. Whereas when we have sarcomatous overgrowth and heterologous rhabdomyoblastic differentiation, it's usually this component that will metastatize. Okay. I will move to the next case. So the next case is a 78-year-old female with biopsy-proven endometrial carcinoma. This is the hysterectomy specimen. Okay, so first, on low power, we notice an epithelial proliferation, a neoplastic proliferation that looks epithelial. But then there is sort of like a juxtaposed spindle cell lesion right next to it. We'll go first on higher power on the epithelial proliferation. Some of it have like papillary growth. Some other areas have more of like a micropapillary and like a glandular architecture. And when we go on higher power, the nuclear features show a high-grade cytology. And I'm not sure if it projects very well on the screen, but it's very easy to see mitotic figures on the microscope. So all these findings, she also, of course, had a mutated P53 pattern. So all these findings are consistent with endometrial serous carcinoma. Now, regarding the other proliferation that was here, it's a spindle cell. It was a nodule, 3 centimeter nodule that was very close to the epithelial tumor. I will show another section. And this is what it looks like on low power. Definitely, there are some cytologically atypical cells and bizarre cells. I will go on higher power. Okay. So hyperchromatic, bizarre cells, cytologically atypical. And when we go, I hope it projects well on the screen. But if we can look, the nucleoli are very kind of orangiophilic and large, and they have sort of a halo around them. And we can see some eosinophilic inclusions within the cytoplasm. So this was an interesting case. Each entity by itself wouldn't have been very challenging, but the fact that they were together sort of raised the differential diagnosis. Are these two different processes going on, or these are the same process? So when we have serous carcinoma and we have spindle cell proliferation, the thing that we think about is basically carcinosarcoma, which is a biphasic tumor with malignant epithelial and spindle cell component. Whereas in this case, as we look on the spindle cell proliferation, we didn't see mitotic activity. We didn't see definite malignant features or like atypical mitoses or like necrosis, tumor cell necrosis. It was mostly these bizarre looking cells with these prominent nucleoli and cytologic atypia. I did P53 on the spindle cell lesion, and on the serous carcinoma, it was mutated, overexpressed. On the spindle cell lesion, it was slightly upregulated, but it's wild type. It's a wild type pattern. And I did one more stain, which is the fumarate hydratase immunohistochemical stain. So these are the normal myometrium, and here is the spindle cell lesion. When we go on higher power, we can see some of the fumarate hydratase expression in the blood vessels, but the spindle cells themselves are negative. So with the morphologic findings and the immunohistochemical finding, this is consistent with a fumarate hydratase deficient leiomyoma. The fact that we didn't see any increased mitoses, we didn't see a tumor cell necrosis, this is consistent with a leiomyoma. And they happen to be two processes that are just juxtaposed together instead of, being a carcinosarcoma representing the same clonal process. And I wanted to show another case of fumarate hydratase deficient leiomyoma that happened to have a lot of these nice eosinophilic inclusions, all of these. And that is the diagnosis for this case. I will show a brief summary. So fumarate hydratase deficient leiomyoma. We didn't have all the features in the slide I showed, so I wanted to put some pictures for the other features that we look for. Usually they have staghorn blood vessels. They have increased cellularity and alveolar type edema. They frequently have multinucleated cells with degenerative atypia. They will have a fibrillary background and these rhabdoid cells, but these rhabdoid cells do not correspond to rhabdomyoblastic differentiation. And the nuclei have large orangiophilic nucleoli with a perinuclear halo. It is important to recognize this entity because it can be part of the leiomyomatosis renal cell carcinoma syndrome. This is an example of the staghorn blood vessels, or like the hemangiopericytoma like here. And this is an example of the bizarre nuclei. So fumarate hydratase deficient leiomyoma and leiomyoma with bizarre nuclei are not the same entity, but they can have a lot of overlapping features. This one had the features of both. These are the rhabdoid inclusions. They do not correspond to skeletal muscle differentiation. They actually correspond to like abundant filament deposition. And this is the typical orangiophilic cytoplasm with the perinuclear halo. This is an example of the alveolar type edema, which is kind of reminiscent of the pulmonary alveoli. Okay, that's all for this case. I will move on to the next case if there are no questions. So the next case, share my screen. This patient is a 53-year-old lady with a biopsy-proven endometrial carcinoma. And this is the hysterectomy specimen. So I'll go on lower quadrant. We have some adenomyosis. The myometrium doesn't have a malignant process infiltrating. In the endometrium, we have this tumor. Which look epithelial. There is a good amount of tubule formation, but at the same time, there is a lot of like solid areas. It is confined to the endometrium. Again, tubular, a solid, and some even have some spindled appearance. Now, at our institution, we do ER/PR for all endometrial carcinoma cases. So on ER, this is ER for this tumor. It's completely negative. So the stroma is positive, but the tumor cells themselves are completely negative. And same for PR. So with the negative ER, I added a few more stains. This is the first one, which is PAX8. PAX8 is diffusely and strongly positive. It's a nuclear stain. And GATA3 GATA3 was also pretty much diffusely positive. It's a little faint stain, but it's diffusely positive. So any thoughts? What could the diagnosis be?
GATA3 will recommend a mesonephric region.
Exactly. Excellent. Yes. So this is mesonephric-like adenocarcinoma of the uterine cavity. We can have that also in the ovary. So mesonephric-like adenocarcinoma of the gynecologic tract. I wanted to talk a little bit about it. It's a relatively recently recognized entity, but we're seeing more and more of this now that we recognize it. So as Lee mentioned, it's an endometrial carcinoma displaying morphologic and immunophenotypic features of mesonephric differentiation. Microscopic features include, the main clue to on H&E is the admixture of architectural pattern, just like in this case. So you see some tubule formation, which is the most common, but there will be also other architectural patterns such as papillary, micropapillary, even glomeruloid. In this case, we had spindled and solid growth. Typically, these cells will be local laminar to cuboidal, and they have a smooth luminal border. Endometrioid carcinoma also have this feature of like smooth luminal contours in the glands. Most of the time, we're able to see some intraluminal eosinophilic secretions, but these are also not specific, and they can be seen in endometrioid carcinoma. So mesonephric-like typically lacks squamous and mucinous differentiation, in contrast to endometrioid carcinoma, which frequently have squamous and mucinous differentiation. The nuclear features, they characteristically have overlapping nuclei with vesicular chromatin that are often marginated. So very similar to the papillary thyroid carcinoma nuclei, or like what we call orphan Annie. The characteristic IHC is very helpful in this case. The main clue to the diagnosis is when you are seeing a tubule formation, but you do ER/PR, you would expect that for low-grade endometrioid, you will have a lot of ER and PR expression. In this case, they will be negative. So that's a very important clue to the diagnosis. And, you know, a differentiated endometrial carcinoma with negative ER and PR usually should raise the suspicion. There are mostly three entities, basically. The most common one being clear cell. So clear cell will have like tubulocystic architecture, but it will be ER/PR negative in most of the cases. The other one would be this more rare entity, which is mesonephric-like adenocarcinoma. And the third one would be the recently recognized entity, which is the gastric type endometrial adenocarcinoma. That one will also have a lot of gland formation, but it will be ER/PR negative. the markers of mesonephric differentiation, it will be PAX8 positive, but it will also be TTF1 and GATA3 positive. CD10 is frequently positive, and it will have a luminal distribution on the lumen of the glands. Just to show quick pictures, so variable architectural patterns, micropapillary, papillary, and glandular or tubular. And these are the typical intraluminal eosinophilic secretions, which kind of resemble the colloid. Less common, but was present in this case, is the spindled growth. So it will have some areas of spindled and solid growth. And this is TTF1. In this case, it was diffusely and strongly positive in the picture I'm showing. Sometimes it's not. Some papers describe what we call like inverse patterns. So the areas that are GATA3 positive are usually TTF1 negative, and vice versa. The areas that are TTF1 positive will be GATA3 negative. And this patient actually, so for a low-grade endometrioid that is not invading the myometrium, it was stage 1A, usually the prognosis is very well. This patient did actually recur very early after her hysterectomy, and that reflects that these tumors don't have a very good prognosis. They have a worse prognosis compared to endometrioid carcinoma with the same stage. Any questions? Okay, so that concludes the third third uterus case. So we reviewed first the adenosarcoma, the serous carcinoma with fumarate hydratase deficient leiomyoma, and the third one is mesonephric-like adenocarcinoma. Now I will move to ovarian tumors, and I'm focusing mostly on epithelial ovarian tumors because this is what we mostly see in our daily practice. I will start with the first ovarian case. Share my screen. So this lady was a 47-year-old lady with bilateral adnexal masses. I'll start with low power view. There is definitely an epithelial neoplasm with abundant gland formation. When we go on higher power, we can see back-to-back glands with sort of columnar tumor cells and, these smooth luminal borders. And I was able to find some areas of squamous differentiation a little bit. So back-to-back glands, smooth luminal border, columnar cells, endometrioid type morphology with squamous differentiation are all characteristic of endometrioid carcinoma. On other slides from the same tumor, we had something quite different. We had these areas here, and when we go on higher power, first we can appreciate sort of tubulocystic architecture, and the cells seem to have a clear or eosinophilic cytoplasm. Some of the nuclei have what we call hobnailing, so the nucleus protrudes into the lumen, and again, some clear cells. So these are typical morphologic features of clear cell carcinoma. Now, so on the H&E, we're seeing two different processes in the same tumor. So we start thinking about mixed carcinoma. I did some IHC, so this is PR on the endometrioid component. And as you can see, ER is very diffusely and strongly positive in the tumor cells. And then on the other component, which had clear cell features, PR is basically negative. It did highlight some like cells, but the majority, 90% of the cells were negative for PR. And I added one more stain, which is napsin A. And as you can see, napsin A is diffusely and strongly positive. So in this context, the concept of mixed carcinoma, these should be rare. They should not be overdiagnosed because the majority of these cases represent more of like a morphologic variant of the main tumor rather than two mixed carcinomas. But in order to diagnose it, we kind of have to have like two morphologically distinct entities in the same tumor, and the IHC completely support what we are seeing on the morphology, because the majority of clear cell change that we see in these tumors are more of like sometimes clear cell cytoplasm associated with squamous differentiation, or just like sort of a secretory or clear cell change of the endometrioid carcinoma. But in this particular case, they really looked morphologically distinct. They did have completely opposite, immunoprofile, each of one consistent with the entity. So this is a very good example of mixed carcinoma. The majority of the tumor was endometrioid in this case, so it had a 70% endometrioid carcinoma, 30% clear cell carcinoma. And in this patient in particular, she had another concept is that the uterus was not available for evaluation when they did the bilateral salpingo-oophorectomy specimen. They didn't remove the uterus. This is something that we should always consider when we don't have the uterus, especially having bilateral adnexal masses. It should raise the concern for secondary involvement from a uterine primary. And indeed, this patient had subsequent endometrial biopsy, and the endometrial biopsy did also have a mixed carcinoma with endometrioid and a clear cell component. And that's all for this case. I can move to the next case. There are no questions. Okay. So this one is a 45-year-old female with a pelvic mass. Start with low power. So on low power, what we can see is basically papillary architecture with hierarchical branching. So we're seeing papilla that are branching from broader papilla, and those are branching from broader papilla. And if we go on high power, we can see a lot of what we call like tufting or budding of the tumor clusters from the main papilla. And in this area right here, we have a very characteristic morphology. We notice that these papilla are longer than they are wide. And this is very characteristic of the micropapillary variant of serous borderline tumor. So if I only had this and this would be a micropapillary / cribriform variant of serous borderline tumor. However, if we look at this area, we notice something different. So the tumor clusters are invading into the stroma. There is a lot of pseudomatous calcification. And when we go on higher power, we notice that we have a lot of very confluent growth of micropapilla that are surrounded by a cleft or like a lacunar space right here. And on higher power, we don't have marked nuclear pleomorphism. So it's a tumor, definitely looking atypical, but we don't have marked nuclear pleomorphism between the nuclei, and the mitotic activity is not very high. So this is a very, very typical appearance of low-grade serous carcinoma in this case arising from a micropapillary variant of serous borderline tumor. I did P53 on this case. So in low-grade serous carcinoma, P53 would have a white type pattern of staining. And in this case, P53 was white type. And in the context of, low-grade serous tumors, so serous borderline and low-grade serous carcinoma, I wanted to talk a little bit about implants. Because I feel that this is a challenging concept in the ovarian pathology. And as a resident, I had to really read a lot to kind of understand it. So implants are present in 30 to 40% of serous borderline tumors. So it's a big percentage. And these are defined as similar appearing lesions in the pelvis and in intra-abdominal sites, including the lymph nodes. So we can have non-invasive implants in the lymph nodes. Now, they are subclassified into non-invasive and invasive types based on the presence of destructive infiltration into the underlying normal tissue. And I will show some pictures on this. And to note here that a lot of these women with serous borderline tumor would have a lot of endosalpingiosis. And these endosalpingiosis can also involve the peritoneal surface and the lymph nodes. So we should distinguish endosalpingiosis from implants because endosalpingiosis are benign and they should not upstage the tumor. So for implants, again, we have two types of implants, invasive, non-invasive. This is a typical example of a non-invasive implant. So non-invasive implant, the main clue, the way I think about it is that this tumor is basically stuck on the surface, but it didn't go through it. It didn't invade it. So because it's stuck and it didn't invade, we have a very smooth border and the interface between the fat, the peritoneal surface, and the tumor is very well demarcated. Almost you can very easily draw a line around it. And this case also. It's not always that easy, but this is a very typical example of non-invasive implant. Now, there is another form of non-invasive implant, which we call desmoplastic type implant. In this case, there will be a very prominent desmoplastic reaction here and inflammation surrounding the scattered clusters of tumor cells. What really catches the attention on low power in this case is that in the non-invasive desmoplastic implant is that the stroma is the predominant component and not the tumor. Stroma is very predominant. We are only seeing scattered clusters of tumor. And the other thing is that it is kind of still well demarcated and it doesn't seem to invade into the underlying tissue. Whereas invasive implant, it has destructive infiltration of the underlying tissue. So first, we are seeing a lot of confluent nest. And second, the distribution of the nest is very haphazard because it has already infiltrated into the peritoneal surface or the omentum. So this is an example of invasive implant. This is another example of invasive implant. So it can be associated with desmoplastic reaction around it, but from low power, we can appreciate that it's epithelial predominant and not stroma predominant. The glands have a very haphazard distribution. They are irregular. They don't seem to be contained within a certain area, and they have already infiltrated the fat. So now, because borderline tumors with invasive implants are associated with an increased risk of recurrence and a more aggressive behavior, these implants are now to be considered basically extra-ovarian low-grade serous carcinoma. So even if we have the main ovarian tumor is only serous borderline tumor, but the implants in the peritoneal surface or the omentum is low-grade serous carcinoma, we go ahead and call it low-grade serous carcinoma. We're not using anymore the term of, invasive implant of the serous borderline. It's a low-grade serous carcinoma, extra-ovarian. And sometimes it's not straightforward and we are not able to classify. So there is an option of just saying this is indeterminate. I'm not able to determine this is invasive or non-invasive. And that's all for the low-grade serous neoplasms. Okay, I will move to the next case, just to kind of compare. In contrast to low-grade serous neoplasm, this is an example of high-grade serous carcinoma, which is way more common than low-grade. So the majority of serous carcinoma and the ovary are actually high-grade. Low-grade is much less common. So we do have papillary architecture similar to the low-grade, and we do have more of like a solid growth. I will go on high power. So in contrast to the low grade, the main histologic feature that we can see on the H&E is the nuclear pleomorphism in high-grade serous, and that's the main differentiating criteria between high-grade and low-grade on the H&E. So we can notice this is a tumor cell, this is a tumor nucleus, and this is a tumor nucleus, and it's clearly more than 3 times bigger than the one adjacent to it. So nuclear pleomorphism more than 3:1 is highly suggestive of high-grade serous carcinoma. The other criteria that we look for is mitosis. Mitosis, more than 12 mitosis per 10 high power field is also very suggestive of high-grade serous carcinoma. But of course, we're going to do the stains, and we do P53. So P53 characteristically have a mutated pattern, which reflects TP53 mutation in high-grade serous carcinoma. Now, in this case, we had sort of a, other than the usual conventional high-grade serous morphology, we had this area here. So kind of a solid area, a little bit of gland formation, more of like the endometrioid type gland, not the serous, and a lot of solid growth. Has a little bit different morphology here and in this area also. So solid with some gland formation that kind of look like endometrioid. So I'm showing this to mention the concept of set pattern in high-grade serous carcinoma. So high-grade serous carcinoma, we have the conventional pattern, but we also have the set pattern. So SET, set stands for solid, endometrioid, and transitional line. It is important to know this pattern because it is still high-grade serous and not to misdiagnose it with, let's say, endometrioid carcinoma. And one other thing about the set pattern is that it can actually be, it is commonly associated with BRCA, BRCA1 and 2 mutations. It is not necessarily germline. It could be somatic or germline, but it is frequently associated with BRCA mutation. So this case, I had the privilege of diagnosing the biopsy, and then I had the resection. So on the biopsy, it was mostly set pattern, and I was able to find the mutation, the next generation sequencing result for the tumor, and the patient did have BRCA1 mutation. Now, this specimen was the resection specimen, the tumor resection specimen, after she had neoadjuvant chemotherapy. And in fact, the majority of high-grade serous now, so when they present at an advanced stage, they do a diagnostic laparoscopy, they take a biopsy, and when the patient is diagnosed with high-grade serous carcinoma, they give the patient neoadjuvant chemotherapy, and then they do the interval cytoreductive surgery. So I wanted to talk a little bit about the neoadjuvant therapy effect. First, if we notice here, now high-grade serous have a lot of, nuclear pleomorphism and high-grade cytologic feature, but it will even get more accentuated when the patient receives neoadjuvant therapy. So the tumor will have very bizarre nuclei. They tend to have a lower mitotic activity. Now this one still had, because she didn't respond very well, but when they respond, the mitotic activity will also decrease. So it's very important to have, it's better to have the diagnosis prior to receiving the neoadjuvant therapy. And in this context, I wanted to talk a little bit about, evaluating resection specimen status post neoadjuvant therapy. So we are more and more getting these kind of specimens. Again, these bizarre cytological changes. We will see some fibrosis. We will see some hemosiderin deposition, and usually also macrophages. And that what basically defines the treatment-related changes or therapy effect or regression-associated changes. Macrophages, fibrosis, and like hemosiderin deposition. The most important thing in these cases is the pathologists have to assign the CRS score, so the chemotherapy response score. I took this from the CAP. I just wanted to note that first we have to do it only on the omentum. We don't do it on the ovary sections. So even if let's say the ovary has a lot of tumor, but the omentum is basically has only very rare residual cells, it will still be an excellent response. And we have to select the blog or the slide that have the least response to chemotherapy. It's a 3-tier system, so 1, 2, and 3, with 3 being complete or near complete response. I will just show some picture. Now, usually CRS1 is very easy to just call it CRS1 because in this case, there will be no to minimal regression-associated inflammatory changes. So we can see some here, fibrosis, macrophages, but there is a lot of tumor. So there is a lot of viable tumor. So this is typical for CRS1. Now, CRS3, in contrast, there is basically complete or near complete response with no residual tumor or minimal irregularly scattered tumor foci that are less than 2 millimeter. Now, I would say in daily practice, it's much harder to distinguish 2 and 3 from distinguishing, 1 from 2 or 1 from 3. So CRS2, the main difference between CRS2 and CRS3 is that in CRS2, we are still seeing tumor foci in a sort of a regular distribution. So I select the worst slide, and pretty much every other field, I am seeing some tumor, or every field. Whereas in the CRS3, it is irregularly distributed. So I pass multiple fields, and I see a scattered tumor cluster. And the largest tumor cluster should be less than 2 millimeter in CRS3. It is a very important prognostic factor, and that's why we kind of spend a good time on it. That's all for the high-grade serous and neoadjuvant therapy and set pattern. Okay, I will move to the next case. This is a 26-year-old lady with unilateral 32 centimeter adnexal mass. First, she's young with a 32 centimeter mass, unilateral. Already the presentation, the clinical presentation kind of suggests mucinous differentiation. Mucinous tumors typically tend to be very large and typically unilateral if it's a primary ovarian. So I will look first at flow power. We can already appreciate the mucinous differentiation. And the majority of the tumor basically have a borderline morphology with some areas that had intraepithelial carcinoma, but the majority of the tumor had a borderline morphology. Other areas were more sort of back-to-back and very complex architecturally. So this is what we call expansile growth of mucinous carcinoma. So she had only a focal mucinous carcinoma in a background of mostly borderline tumor. Now, the interesting thing in this case was these areas. So Grossly, the tumor was very large, the majority of which was cystic, multicystic, and she had two or three distinct sort of like mural nodules. So grossly, we call them mural nodules, and they were very clear and easy to appreciate and identify. The largest of which was 5 centimeter. So on the microscopic examination, the majority of these nodules has this appearance, so abundant hemorrhage. And when we go on high power, there is a lot of basically multinucleated giant cells right here, right here, right here, and with interspersed mononuclear cells, all of them having like sort of an abundant eosinophilic cytoplasm. There were so many mitoses, and some of them were atypical mites. I'll try to find. Not sure if they project well on the screen, but there was a lot of atypical mitosis as well. And whereas these areas appear to be kind of contained and well circumscribed, there was a little bit of sort of like an infiltration at the border. And the degree of cytologic ATPO is very pronounced. So this opens the subject of a rare finding. So it's very rare, basically. It's the having a mural nodule associated with ovarian mucinous neoplasm. So ovarian mucinous neoplasm, whether benign, borderline, or malignant, most of the time it's the borderline or malignant, but sometimes also the benign. So like the mucinous cystadenoma can be associated with mural nodules. And these mural nodules can be benign, malignant, or mixed. So the benign will have different forms and the malignant will have different forms. But the most important thing is to distinguish whether it's benign or malignant. The malignant can be an anaplastic carcinoma or a sarcoma or even a carcinosarcoma. And you can have a mixture of both. In our case, we actually had areas that were typically benign sarcoma-like, but there were areas that stained with keratin and very high-grade nuclear pleomorphism, very abundant brisk mitotic activity with atypical mites. So we had also a component of anaplastic carcinoma. Grossly, usually the benign nodules will be sharply demarcated and smaller in size, whereas the anaplastic carcinoma or the sarcoma would be large, and usually they will have some infiltrative borders and will have extensive necrosis. I will show some pictures. So this is a typical example, very similar to what we had, a sarcoma-like mural nodule. It will have abundant hemorrhage. And on high power, we have these multinucleated giant cells with interspersed mononucleated cells. And it's very easy to find mitotic activities, even in the benign mural nodules, usually in the range of, up to 12 mitosis per 10 high power fields. Anaplastic carcinoma, this is an example of anaplastic carcinoma. It's usually more infiltrative. And so it can be actually confused with, like a reactive process, but these will look cytologically atypical and they will stain at least focally or patchy with keratin. And we can have more than one. So in this case, this area right here is more of the anaplastic carcinoma that is infiltrating into the stroma. And the area right here is more of the sarcoma-like benign mural nodule. There has been a recent paper suggesting that both, whether it's benign or malignant mural nodule, they are sort of clonally related. And, it's not like two distinct entities, but rather more of like a spectrum. So with that, I conclude the topic of mural nodule associated with mucinous tumors, ovarian mucinous tumors. Okay, so I think we're done with the epithelial tumors. I will try to show. So ovarian tumors, we have epithelial, sex cord stromal, and germ cell. Those are the main three categories. This is kind of epithelial, but in a more of like the miscellaneous category, not the typical epithelial neoplasm. Okay, so the patient in this case is a 1 year old, a female with a pelvic mass, and she had serology finding of hypercalcemia. She had elevated calcium levels in her blood. Now, on low power, we can notice it's a very cellular hyperchromatic tumor with pretty much most of it has like sort of a diffuse growth. Some areas had a little bit of like nest formation, but the majority was a diffuse and trabecular. When we go on higher power, the tumor had abundant mitotic activity and high-grade cytologic features. Okay. I would say we did a lot. We did stains on this case, and it didn't have like a typical, a staining pattern that would match, let's say, with sex cord stromal or epithelial tumor. So it had like a focal inhibin, focal WT1. It didn't have like a specific staining profile. So we did on this case the SMARC-A4 immunohistochemical stain, and usually this stain have a nuclear expression. In this case, it was lost. So this is a very characteristic feature, and with the clinical presentation and the morphology of the small cell carcinoma hypercalcemic type. It's a rare tumor, but it's very important to recognize it. Unfortunately, it has a bad prognosis, especially when it presents at a higher stage. So small cell carcinoma hypercalcemic type is basically an undifferentiated neoplasm composed of these small round cells that are often associated clinically with paraendocrine hypercalcemia. Now, on the microscopic examination, it typically has this diffuse growth, but it can have nested, corded, or trabecular, or even single file. I didn't have follicle-like spaces in this slide, but the tumor did have sort of a follicle-like spaces, and I will show pictures. These are present in like 80% of the tumor, but characteristically, you will not have a lot of them. So you will have in occasional slides, but there's not very many of them. And they typically have eosinophilic fluid inside them. This tumor has a brisk mitotic activity and extensive areas of necrosis. The characteristic IHC, as I mentioned, is the SMARC-A4 loss of expression. This is the picture of, like the diffuse growth of small blue cells. And these are the follicle-like spaces that I mentioned. So they will have sort of like an eosinophilic secretions inside them, and you will not have a lot of them in the tumor, but you will see them in 80% of the case. So the main differential for this tumor is granulosa cell tumor, particularly the juvenile type. She's young. Grossly, both tumors tend to have this kind of tan yellow appearance. And the staining pattern, if you didn't do SMARC-A4, it will be also confusing. So granulosa cell tumor, particularly the juvenile type, would be the main differential. Some papers I saw suggested that the juvenile type of granulosa cell tumor will have a lot of these, follicle-like spaces. They suggest that typically the small cell carcinoma will have these eosinophilic secretions, whereas I will show a case, the juvenile granulosa cell tumor, so I have a slide here. This is a case of a juvenile granulosa cell tumor. It has a diffuse growth. And if you notice, there is a lot of these follicle-like spaces almost in every other field. And when we go on higher power, the secretions within these follicles are kind of bluish. But of course, we will need stains to differentiate. This patient was also like I remember a 2-year-old lady with a pelvic mass. So the clinical presentation is also very similar. The morphology and the distinctive SMARCA4 loss of the small cell carcinoma would differentiate. Juvenile granulosa cell is, of course, much more common than small cell carcinoma hypercalcemic type. So I will move to the last case, I think. I wanted to show this case. So this is a typical adult type granulosa cell tumor with a very, macrofollicular and diffuse growth right here. And this macrofollicular architecture. Our case, she's a 53-year-old lady who had just a small 2-centimeter nodule in the ovary, and pretty much it all looked like that. It's diffuse growth. What looks like, ovarian stroma. On low power, it seems very well circumscribed. And it all look the same with these kind of diffuse growth. And in higher power, it appears a little bit, kind of has a pink plump cytoplasm, sort of like luteinized cytoplasm. So this is an example of less common variant of, adult type granulosa cell tumor with luteinized features. Now, diffuse architecture is very commonly seen in granulosa cell tumor, but sometimes we're able to see other, macrofollicular architecture called Exner bodies. But in this case, the whole tumor was like that. I did reticulin in this case, and it clearly highlighted nests, big nests of tumor cells. And this tumor was also sent for FOXL2 mutation, and it was FOXL2 mutation positive. Characteristic of adult type granulosa cell tumor. I would say if we didn't think about it, it can be easily interpreted as a stromal tumor like a fibrothecoma or a fibroma. But in this case, this is a adult type granulosa cell tumor. So I will stop here, and I'm happy to take any questions. I can see some questions in the chat. Okay, so this is probably on our second case. Somebody suggested carcinosarcoma. That's an excellent differential. It is indeed the main differential diagnosis between, like a bizarre leiomyoma with fumarate hydratase deficiency that is right adjacent to the serous carcinoma. So this is a very good differential. Again, the P53 in this case was wild type in the spindle cell component, and it had the fumarate hydratase deficiency. Did you use the term auto-implant for serous borderline? I don't use it that much, but it is, it means that it's basically surface implant of the same tumor on the ovarian surface. It doesn't change the prognosis. I don't use it very often. And thank you. I think those are the questions in the chat.
Thank you, Dr. for this great lecture. It's answered a lot of details. I have a quick question. If a mesonephric-like cancer arising from the lower uterine segment, maybe involving the cervix, how to differentiate from the cervical mesonephric carcinoma? And
Yes.
Is it clinically important? Because sometimes it's very similar. Like, is it important to differentiate from it?
Yes. So the tumors usually in the cervix, it's sort of the mesonephric adenocarcinoma. The main difference between them is basically, so in the cervix, it's actually a true mesonephric adenocarcinoma that arises from the mesonephric remnants. So usually you will have if you sample the cervix very well, you will see the tumor, but you will also see areas of like mesonephric remnant. The kind of the spectrum. You can have like mesonephric remnants, mesonephric hyperplasia, and then when it infiltrates and invades, this is mesonephric carcinoma. Whereas typically in mesonephric-like adenocarcinoma of the uterus and of the ovary, these you will not have, usually you will not have mesonephric remnant. It's more of it is similar to the mesonephric carcinoma, but it's not actually arising from the mesonephric remnants. Does that answer your question?
Yeah, absolutely. Thank you.
Dr. Atwee, this has been a wonderful presentation, and I think the enthusiastic response and questions here are very, very telling in terms of how you've helped people clarify some really challenging differential diagnoses. So I can't thank you enough for taking the time to prepare, and your slides were excellent. Unfortunately, I guess we don't have digital slides that we can share and have people study afterwards, but certainly if there are other questions that come along afterwards, don't hesitate to reach out to me, and I'll pass it along to Dr. Atwee as well.
It's my pleasure to be here. Thank you so much.
Thank you.
Well, very good. Thank you all for joining today, and we will look forward to meeting again at another time next month, similar. And for today, hope the rest of your day goes very well. Thank you again.
Bye.